C'est moi? Non, c'est Nithya qui va commencer.
Yep.
C'est? Elle parle pas? Nithya?
Yep.
Ouais.
All right.
Start.
All right. Perfect. Thank you very much. Hi, everyone. Welcome to the second session of this minimally invasive surgery webinar series called How to Continue to Develop Your Minimally Invasive Surgical Skills During the Pandemic and What Does the Future Look Like? We're all living in a very unprecedented time that has caused a lot of pressure and having to deal with constantly evolving challenges and pushing us to transform the way we do surgical training. Especially laparoscopic training is no exception to that. Please join me to learn and understand how some of our experts had to take the bull by the horn, especially in being creative in their approach to training their peers, residents, fellows, or even themselves in such situations. With that, please take a moment to review the housekeeping rules of the webinar. And without further ado, I will pass the baton to Professor Dalaman, who's the panel moderator of the session. Professor, over to you.
Yes, good evening, maybe good morning for some of you, or good afternoon for the majority probably, because the chance of this webinar is to go all over the world. And so usually we're going from Latin America to the East. So welcome to this webinar organized by Medtronic on the importance of COVID pandemics on the educational programs in the different institutions, different countries, different centers. So it's a very important topic. As you know, that everything starts early this year, and we have seen a lot of change in the programs of education in the different institutions. And for example, I know that in the United States, some institutions have reduced significantly the number of surgical residents in the different units to avoid this potential contamination, reduce the number of people in the different wards, etc., to try to stop the diffusion of the virus. So, of course, reducing the number means reducing also the educational program for these different young surgeons and the programs of education. So it's very important. We have also a big impact in institutions that are really focused on education, like IRCAD in France or IRCAD in the different countries that we have in the world. Because as you know, we have to stop all our educational program with people on site. And we're using more and more this media to trying to preserve some education all over the world. So it has a very big impact, and I think it's a very good initiative from Medtronic to organize this Medtronic when we will get people who are used to work in education and get a little bit the opinion regarding what we have, what we should do, what we have to aim to in terms of education. So it's a very difficult period of time for the education people, and that's why I think it's extremely interesting. So Medtronic has organized a very nice faculty, because we have people from England, we have people from the East, from Poland, we have people from France, I'm here. And so together we will try to review all the main concerns that we have, and possibly or potentially the solution that each of these experts have developed in their own institution or their own country. So I'm very pleased to share this table and this studio with Olivier Matonnet from Medtronic. He will be a little bit the moderator with me, because he will catch all the questions, remarks, suggestions from the audience. So as you were told just before, if you want to ask some question, just write on the Q&A item on the Zoom platform, and we will get this question. Olivier will try to group this question and we'll ask the question to the different speakers. So my role is just to chair and trying to organize this discussion. So I'm very pleased with that. I think that we will start with Olivier because we have prepared a poll question. So poll question is what? We will give you a question, and on your platform, you can answer this question, and rapidly we'll have the response, so we can share with you the response from this poll. So Olivier, you have the chair.
Absolutely. Thank you, Professor Dallemagne. So before starting the discussion, so we would like to capture your feedback on two questions. So the first one is, do you think that the mini-invasive surgery training will go back to pre-COVID days? With multiple choice, yes, no, not sure. So we'll just wait 10-15 seconds before displaying the results. I think, yes, we can display the results by now.
Can we have the results? Okay.
Oh, yes, the responses are well balanced. So between the yes, the no, and not sure. So it's interesting. So you will try to answer, the question during the discussion. Maybe let's move to the second question. What kind of training resource was available during the COVID-19 period? With multiple choice, webinars, virtual workshops, e-learning, over. Just 10-15 seconds to reply. I believe we can now display the results. So yes, the majority with 87% is webinars. Virtual work, the second one is e-learning with 65%, followed by virtual workshops, 56%, and others 13%. Thank you very much for participating to these questions. So I believe now
it's a strange question, because when we discussed with Medtronic previous to this session, webinars are everywhere, and you have different types of webinars. You have webinars where people are attending lectures and they cannot participate. You have webinars where you have some live surgery, which is more a live event. You have webinar when you have lectures and discussion with experts. So the possibilities of this sort of video conferencing are enormous, because we can use it in the different ways. And this is also the goal of this session, is really to try to see what would be the impact of these different types of webinars, different models of webinars. And again, with the participants, we will try to see what corresponds the best to the wish of the potential audience. So this is a really good start for this session. So I want to introduce the different panelists, and I will ask first, ladies first, of course. I will ask to Dr. Gupta to present herself and explain a little bit why she's attending this session.
Thank you very much, Professor Dallemagne. So my name is Sharmila Gupta. I'm a consultant colorectal surgeon in Colchester in England, which is a very old Roman town in England. And I'm clinical lead for surgery there. I'm very much involved with surgical training in laparoscopic surgery, not only in colorectal surgery, but in other specialties such as training trainers in urology and gynecology, thoracic surgery, all different things, through my work with an organization called LAPCO. And I've been working with the LAPCO team with Medtronic for a couple of years now, delivering training in the CEMA region to try to improve the standard of training for surgeons who are doing laparoscopic or endoscopic surgery. So it's a real pleasure to be here with you all today, and I'm honored to be invited. Thank you, Professor.
Thank you very much. So that's of course a perfect profile for this sort of discussion, because training is one of the main issues of this special period. So the next speaker will be from Poland, is Dr. Piskowski. And again, I invite you to introduce yourself and a little bit the background of educator that you have. Thank you.
Good afternoon, everybody. Thank you very much for the invitation for this meeting. And I'm a thoracic surgeon. My name is Cezary Piwkowski. I am a head of the Department of the Thoracic Surgery of University of Medical Sciences in Poznań. Poznań is a city in the western part of Poland, just in the middle between Warsaw and Berlin. We are just one of the leading major thoracic centers in Poland, with a volume of 400 major resections due to lung cancer per year. And we started our minimal invasive surgical program in thoracic surgery, in VATS program 20 years ago. And we were involved for many educational events in Poland for surgeons from our country and also from Europe and other continents as well. Just focus on major resection due to lung cancer. Major resection, it means lung anatomical resection of mediastinal tumors due to malignant tumors since 15 years nowadays. Thank you very much once more for invitation.
Thank you very much. Nice profile. Of course, thoracic surgeon, we're thinking about the lung and lung COVID. There is a close connection.
Yeah.
So maybe you can answer some specific question when we're talking about some prevention or whatever. So it's good to have your profile with us today. So the next speaker is from London, is Dr. Mac Monagle. And I invite you also to introduce yourself. Thank you for being with us.
Thank you again for the kind invitation to present. My name is Morgan McMonagle. I'm both a trauma and a vascular and endovascular surgeon. And I'm really wearing my hat today as one of the leading educators at the Royal College of Surgeons in England, where I direct a trauma course called the Definitive Surgical Trauma Skills course. I also work quite closely with Digital Surgery and Touch Surgery, now owned by Medtronic, in developing online and virtual forms for the continual education of surgeons. My minimally invasive experience is really in the role of endovascular surgery, and I also do some thoracic work as well as the previous speaker. And I hope to share some of my experience today on the platform with what the present and the future may look like for training our up-and-coming talent of the future.
Thank you. Again, I think that the selection was excellent, because we have a specialist on the web education. So we are covering the different topics. And so I'm moving to the final speaker, someone that I know very well, because he's a very long time partner of IRCAD, is Arnaud Wattiez. So Arnaud, I think that you need to introduce yourself. I won't do it.
Yeah, thank you, Bernard. So I am Arnaud Wattiez, and I am a long partner because with the IRCAD. So my my journey was very long, because I started in Paris and moved to Clermont-Ferrand, where with Professor Bria we set up the first center for training endoscopic surgeon in 1989. So it's not yesterday. And then with Jacques Maresco, I participated to the creation of the IRCAD in 93-94. And then I joined IRCAD definitely in 2004. And then I moved later on to Dubai, where we also create a new school of laparoscopic and minimal invasive surgery, which is called MIS Academy. So I think I have a long journey beside my surgical journey in education. And so I think that this COVID has been obviously a shock for everyone. So if I just put on the side the medical aspect of the disease, but let's say it has been also a kind of opportunity to to rediscover and relook at what we do clearly, and to take new position that will, in my opinion, let some print in the future, and the positive print, because I think that we can do probably better than we were doing. So I'm very glad to be part of this panel. And I thank you, Bernard, obviously, DRCAT, but also Medtronic for the kind invitation.
Thank you, Arnaud. So again, the profile that is perfect, because I know Arnaud for a long time, probably back to the early 90s, and he has a huge experience in practical training, so organizing a lot of sessions. So this is a very nice panel. So I will move to the discussion, and what I'm going to do is to ask you some questions, and to start the discussion, I will assign the question to one of you. And of course, after the first speakers, we will try to share the topic, so it will facilitate the beginning of the discussion. So the first question that I have is, how did the training and education pathway for minimally invasive surgery look like pre-pandemic? So that's a chance for you. Arnaud did it a little bit, but to explain a little bit what was your experience before this period of time. And I will start with Dr. Pitkowski, just trying to explain what it was used to do, the ways providing education at the time, in the past time, I would say, I won't say in the past century, but in the time before. It's interesting to establish the new path for the future. So thank you for starting this discussion.
Okay, so we as a thoracic surgeons were involved in 3 pathways for training, let's say. The first pathway, the residents in thoracic surgery, which usually are just kind of like a staff member of our department. So I skip this topic. The other group is the surgeon from the residents from others, let's say, surgeries, like general surgeons, orthopedic surgeons. And they used to come to us and to join us for a few weeks, like for a short fellowship. And the second pathway, which is mostly focused on minimally invasive surgical, focus in VATS surgery, are usually organized. There are special courses on different levels, which were organized for thoracic surgeons or for residents who just want to start or already started, and they want to improve the minimally invasive program, VATS program in clinical practice. And these courses were usually organized with cooperations with our Society of Cardiothoracic Surgeons of Poland, or with cooperation with some companies, medical companies like Medtronic, like Clinical Immersion. Usually this kind of courses were really focused on the practical issues. So usually we hosted the group of 2 to 4 surgeons, sometimes with, sometimes without the scrub nurses, as a group for 2 days. And during these 2 days, after case presentation, every day there was 2 live major resection, VATS major resection, and then discussion about the technical issue, clinical issue, and so on. Of course, as I mentioned before, the level of this training depends on the experience of the participants. However, after that, the next day, the participants or trainees could see the patients after surgery. They could see the X-ray, how we manage the chest tube, and so on, all these practical things. And also the next day, there was 2 next live surgery. And we perform this kind of courses about 4 to 6 per year. It depends on the interest of the surgeons. Usually, because we started this minimally invasive program 20 years ago, and it developed slowly in other centers. So most of thoracic surgeons from Poland came to us, but also some from UK and other countries as well. Nowadays, this kind of training stopped, but we can discuss it later, why and what we can propose for that. So
Okay.
that's how it looks at our, let's say, thoracic division in Poland.
Excellent, excellent. Maybe we can continue a little bit on the same type of surgery, going back to England and the experience of the Royal College of Surgeons in England. So can you comment a little bit on that? What was the attitude of the college and your own experience with this sort of training? Of course, we won't discuss your web platform because probably we'll discuss that later.
Sure.
But what was the method of education that you defend with the Royal College?
Well, as it happens, people are finding it more and more difficult to take time off work and to actually travel to what you might consider traditional courses. And many of the profiles of the courses at the Royal College of Surgeons in England were dissection-based, group format, lecture-based, and then cadaveric dissections. And in many ways, there's been a shift away from that in most parts of the Western world right now for a variety of reasons. But I think one of the biggest reasons, certainly in the UK and in Ireland, is people are finding it more and more difficult to take time away from work. As it so happened, we had been working on some modular training courses or modules as part of courses at the Royal College of Surgeons, not to take the place of dissection courses or indeed minimally invasive hands-on courses, but really to augment them in a sort of auxiliary pleiotropic sort of way. And that's one of the key areas we had been working on, because whether we like it or not, the generation coming through are far more advanced in their higher thinking when it comes to computers and virtual learning. And I think it's something that we should embrace and be a part of the solution rather than try to resist. I don't think it's an absolute solution for hands-on training, but I think people and trainees can come much better prepared to a course or to the operating room as a result of embracing this change. So I think we can either be part of the solution or we become part of the problem. I think one of the big differences that we're seeing now is that we need to plan things a lot better, whether it's patient care or training. We need to plan well in advance because of COVID. And I think that's something that will stay with us when the COVID pandemic finally passes. And I think it'll stand to make better surgeons.
Okay, thank you. What about colorectal surgery or colorectal surgeons providing education? So Dr. Gupta, what was your program before COVID? Was it mostly theoretical or clinical, like we've seen in Poland, or based on hands-on? What is the philosophy of your training programs?
So in the unit where I work in Colchester, before the pandemic, it was very much a hands-on training. So in our department, we have 10 middle grade doctors, so residents in other countries, 3 of whom coming from the deanery, which is like a national training program, and 7 are fellows from all over the world, currently from Italy, from Romania, from India, from all places. And what we try to do is with each of them, when they start the placement with us, define their learning objectives and agree what we're going to achieve with them out of the next 12-month period. So we start off with very much defined goals. We then try and make sure that each trainee gets to the right theatre list to be able to participate in the right cases. And we practice, I think, Mr. McMonagle was saying about the modular-based training. We look at a modular-based training for our laparoscopic colorectal surgery. So, for example, in an anterior section, we break it down into the component parts. And it may be that a junior trainee can do one of those parts of the operation, but a senior trainee can maybe do the more complex part of the operation. So just because you've got one case, it doesn't mean you can only have one trainee participating. And it's really important at the beginning of each operation, we define what everybody's going to do in the case, so they feel that they've actually achieved something at the end of it. I think the other thing that really helps in our unit is that we have a very standardized way of operating. So all the colorectal surgeons, do all the cases in exactly the same way, the same steps. So you can have one trainee be with one surgeon 1 week and a different surgeon the next week, and it's identical the way that we approach the operation, and they find that that's very helpful. And I think the other thing that's really important when we're talking about training and making it effective is that the trainees get immediate focused feedback, because the best way for them to improve rapidly is to get feedback straight away after the case.
Very interesting. Yeah, it's interesting to discuss that afterwards, and I would like to have some advice from Arnaud, because I know that Arnaud, besides the formal courses in IRCAD, has also developed some long program, keeping the people together with him on a long process. So Arnaud, maybe you can comment a little bit on what you were used to do, combining this online education plus hands-on training. So what was the attitude before COVID?
But before COVID, you know, I must say, you speak, before COVID, we were not doing at all online training, and always, you know, as the previous speaker, we all do the same. So, I mean, you have the pre-graduate and the postgraduate teaching, and we all use the same way, hands-on courses, etc. So I think that, you know, we were looking before COVID, and I promise you that since the start I organized courses, I was trying to get homogeneous groups, to try to get the people at the same level, to bring them another level. And so we were always embarrassed, and you know that in the IRCAD, that sometimes you have binomes that were on the training, hands-on training, and one is at a certain level and the other another level. And so, I mean that using the classical way, so making on-site courses, bringing the people together, using lecture, live surgery, labs, etc. I mean, we always have two problems, in my opinion. We have the homogeneity of the groups, and two, the follow-up. And so I think that mainly before this period, I think that this has been my problem for the 20 plus years that I was doing that. I said, how I can make this group homogeneous, to bring them to one level which they all have, to another level that probably they will not have all, but at least they can reach. And two, how I can know that the teaching we have made, you know, bring them to A, to not Z, but probably C or D or whatever. So the follow-up. And I think that what I like now is, with all what happens, and it's not finished, I think, that we find some tools that probably will help us to answer to those questions. Probably not the homogeneity, but at least the follow-up. And so this is my hope. So this is the lack we had, and this is my hope for the future, to be able to answer to those questions.
Thank you, Arnaud. So what we've seen is that I would say that the majority of people are using the same tools for education. Of course, we have the education on site when we have teaching hospital, we have the residents. Residents are sharing the experience of the surgeon, so it's quite easy. Then we have a certain population that is still, some of them are still jumping and starting in laparoscopic surgery. So as Arnaud is saying, this may be all the people with different level of experience. So this is a heterogeneous group, so it's very challenging. What we learn is that also people are using, I would say, formal education. That may be something that we can use online, of course, in a hybrid forms of education, so mixing online. And the question is, of course, today probably the question of the hands-on, so the practical part of the education, which is very sensitive today. So I will turn towards Olivier and ask him if he has some reaction from the audience.
Yeah, not so far, so yes, I think we can continue.
Yes?
Yes.
Okay, so I have other question, of course, prepared by Medtronic. So the second question, surgeons had to adapt to the new normal or virtual. How did you adapt yourself to this situation? So this is your own experience. And I will start with Dr. Gupta. So really, what have you done in this new world?
So thank you. So, I mean, it's interesting. The pandemic happened. We've never experienced anything like this. And suddenly everything was different and it was changing every day. But we have a responsibility to our trainees. And the biggest change was they weren't coming into theatre, because whereas we normally would have the residents operating with us supervising, it was very much consultant-led. And so we had to think about how can we maximize the training opportunities for them if they can't come into theatre. And I see it that there are two aspects of being a surgeon. Everybody, as a surgeon, we love operating. The trainees want to operate all day, every day. But actually, it's the technical skills are one aspect of it. But really what makes an excellent surgeon, I think, are the non-technical skills. So we try to focus a bit on both. So with the technical skills, we're very lucky. We have a surgical education centre called the Iceni Centre with laparoscopic simulators. So we did a lot of simulator training with them. The Association of Laparoscopic Surgeons in England has something called LapPass, which is a certification, if you like, for laparoscopic skills. So we spent a lot of time and energy doing that with the trainees. And also, you know, they were watching us as well. So even watching experts operate can improve your skills. But we also focused on the non-technical skills, the decision-making. So having virtual teaching sessions, virtual grand rounds, discussing patients, and helping trainees improve their decision-making skills. And I think the whole experience of the pandemic taught them a lot about team working and the dynamics of that. And it's a really stressful situation. And as consultants, hopefully we were also teaching by being good role models to them. So we took a slightly different view of trying to concentrate on those non-technical skills where we could, and training them with a simulation as well at the same time.
Thank you. So this is a good summary of what we can do with our residents, because this is very important. It's really the first line of education. So good information. And I think we're coming a little bit close to what is done in Poland. So my question to Dr. Pitkowski, how did you continue your education program? Do you have to change something or to adapt because of the COVID? Because I know that you're accepting people from abroad. So what has changed in your program?
Okay, so this minimally invasive courses just stopped. We do not continue that because of different reasons. Mostly, there was also the company decision that they stopped or organize them and didn't invite anyone to our center or other centers as well. But in fact, in our, let's say, university part of training, we moved much more to the online training, and also, but it's mostly for the students. When we are talking about the residents, which are at our department, in fact, we didn't change anything. We still continue the training in the same way, because we still work in the same way, in fact, of course, following the safety rules and all the things. What changed in the practice, in clinical practice, is just all the consultation. There are much more online. The MDT meeting for lung cancer are mostly online meetings. So we just moved to this online or virtual meetings for this clinical discussion of the patient. But when we just talking about the training of the surgical skills, In fact, we just all the, let's say, organized courses, practical hands-on courses were stopped. But this residence training is follow as before, in fact.
Okay, yeah, makes sense. Yes, in London, what is the attitude of the St. Mary's Hospital and of course the Royal College? What is the current situation when we're dealing with this program of education? What has changed?
Yeah.
Stopped, moved?
Well, certainly it stopped initially when the COVID struck. Everything seemed to grind to a halt for probably between 6 to 8 weeks. But I would certainly echo exactly what the previous two speakers just mentioned, in that there were a lot of other areas to concentrate on. And although surgical residents and surgical registrars get very anxious and concerned when they're not operating and the logbook tends to suffer, you can use that as an opportunity, as Ms. Gupta said, to really focus on the other non-technical skills of surgery, because they have an entire career ahead of them. As regards the Royal College of Surgeons, all courses stopped, but we restarted again in September. Recently gone by, we've held one course that was cadaveric based, and we held it at the University of Cardiff as an outreach course from the Royal College here in London. And we've just had to adapt. We've had to adapt to the new environment of the social distancing, being more particular about the protective clothing and equipment, about people making sure you keep at least 1 meter apart. If anything, I think if we are to take something optimistic out of it, I feel it's that people tend to concentrate more. People feel that I have an opportunity today to learn, and I need to use that opportunity. Like, for example, even in the hospitals, if we're having morbidity and mortality meetings or teaching meetings, people now don't have to be physically in the building or in the lecture hall. They can do it via various platforms such as Zoom. So I think they will use those opportunities. And similarly, and this is just my opinion, I think a lot of hands-on courses, whether it's laparoscopic or thoracoscopic or cadaveric based, I think we might find courses being shortened in the future going forward. So we may have to put half the number of participants through on day one and the other half on day two, rather than all going through on a 2-day course. And they will have to do a lot of prep work beforehand, perhaps via modules online or meetings such as this. And I just think it's going to be a new norm that way, but I think it should be just as effective.
Yeah, thank you very much. Arnaud, what is your attitude today? I know that in IRCAD we had to cancel some of the gynecologic course. So what is your feelings about this? How do you change that? I know that you have developed this online platform, but how can you manage this hands-on, which is also very important in terms of education? So how do you organize yourself today? For example, I know that you cannot come to Strasbourg, so probably I'm asking you about your work in Dubai. What are you doing today?
I think that it has been very well described by my predecessor, and mainly Professor Pikowski. I think that for the graduate teaching, nothing has changed because we do the same. And so my resident, my senior resident, including my fellows, still have the same type of teaching, and except when we stop elective case for a while. But now that we are back to normal, and even we are more load because of the past cancellation. So I mean that they have exactly the same teaching. Now what has changed is the postgraduate teaching, which is very important in minimally invasive surgery and very important nowadays, because even at my time, my boss was telling me 50% of your knowledge will be obsolete within 5 years. And so I don't know if this is the right number. Probably is more now because the technology. So it means that the postgraduate teaching is a real issue. And this one has been really, in my opinion, affected by the COVID much more than the graduate education. And so this postgraduate education, as you say, we have canceled, for example, since March. The last course of Gagny in IRCAD was in March. The next one is planned in December, but I'm afraid that looking at the situation, I'm not sure we are going to maintain it. For our on-site course in Dubai, we have canceled all of them since now, but we find solution, and I think this is part of one of the next questions. So this is what is a pity, because courses were quite efficient, but also were quite limited for the reason I told that. I mean that we had no feedback about the efficacy of our teaching. Now I think that in the future, and this is when you ask me what I try now is to answer to those questions, is how I can provide, without being on-site, the same education, and we will talk about the hands-on, and how I can get, in addition of the previous time, how I can get the feedback, how I can follow those people, how I can help the development, how I can proctor those people. And this is amazing what we have achieved in 6 months in that aspect. You know, if I tell you that, just look this conference 6 months ago, you know, it was even not something we would imagine easily to just connect Zoom, share your microphone, and that's it. So I mean that this technology, when we have to metabolize this technology first, then we have to be creative. And I'm sure that what we will develop in the future will be not only the same, but will be much better than what we were doing in the past. And so I don't say that the on-site courses will disappear, certainly not, but they will be accompanied by an online follow-up that will be there, and that will increase the impact of those courses.
Thank you, Arnaud. I think that you were right to make this distinction between graduate and postgraduate. This is very important. And I mentioned initially, j'ai de l'écho moi ici. I mentioned initially that in some institutions in the United States, they even have to reduce the graduate education because they reduce the number of residents to reduce the number of people in the hospital. So it's a very strange word, but this graduate people are probably the easiest one to maintain in education because they have access to the operating theaters, etc. So you can combine non-skill education and skill education together. But postgraduate is probably the most difficult, and that's probably also why Medtronic is pushing for this sort of discussion, trying to understand how they can help in providing this postgraduate education. So the next question was quite similar, and some of you have already answered a little bit to the modification of your attitude regarding education, what you've done, and Arnaud explained very well what has changed to train the different people around you. So I think that probably if some of the faculty do have some slides to help people to understand what has changed in their program, I would ask to Dr. Gupta, do you want to show some data or some slides to explain what is different today?
So, I mean, I can show my slides now. I will just share my screen. It will take a minute. So hopefully you can see that.
Yes, excellent.
Is that okay? Good. So just very briefly, I can't go to the next slide for some reason. Just give me a minute. So it's always interesting when we're online. It worked perfectly when we did the trial, but I can't get it. So I'll tell you what, why don't you move on maybe to the next panelist, and
Okay.
I will have a play and see if I can get this sorted.
Olivier has a question.
Yeah, so I have an interesting question from the audience. So it's a question about the follow-up. So it's how to assess my training when I switch from face-to-face to virtual training. Do you have any data showing the effectiveness of virtual training that it is equal to the traditional ones?
Arnaud, can you answer that?
No, we have data. We have data on virtual training compared to classical training before the COVID. That we have data that are given by the company that promote virtual trainers, and they show that for specific tasks, the virtual training before going in training had the value, and that the people that get the virtual training are much better than the one that didn't get that. But in fact, my experience is when we say what is virtual training, is virtual training using a virtual model, or nowadays due to COVID, what we do is virtual. This is an abuse of language, but this is what we say. So amazingly, and this is probably the question you will ask me, so I cannot answer to your question before you ask me the question, but we have here data to show, for example, hands-on training online get better results than on-site training for certain tasks. And so, and this is one of amazing value that we got from this period, where if you asked me 6 months ago if I believe that we could do hands-on training online besides simulator, I would have told you no. But not now. We have launched this, and we experience now several courses already done with feedback, and the feedback is at least the same, but many times better than the on-site training courses, and I can explain to you why after.
Thank you. So back to Dr. Gupta. Does it work? We've lost Dr. Gupta. Ah, no, she's back with good slides.
Let's see. Can you see that?
Yes.
Wonderful. Okay. So what we've been really trying to do is use what we call the LAPCO methodology. So just very briefly, LAPCO came about as a Department of Health program a number of years ago. And from that, we've developed a course to train the surgical trainers. So to teach people to deliver training more effectively. And what we've shown is that it shortens the learning curve most effectively. And I'm sure a lot of people will be familiar with the Kirkpatrick way of evaluating training. And if you look at the bottom of the, put it here, at the bottom of this, you've got level 1, which is just if you get to give some training to some trainers, did they enjoy it? Well, that's neither here nor there. What we want to do is know is did they learn anything from it? So what we did in this LAPCO course is that we gave training to the trainers, to the experts, and we looked at their competence as a trainer before and after having the training, the course, and we found it improved their competence as a trainer. But then what we wanted to do is have a look, have a look if it actually changed their behavior as a trainer. And so we asked their residents to assess the trainers before they did the TT course, the LAPCO course, and after. And we found that the residents found their trainers were better and were more effective trainers after doing this. And then we looked at the next level, level 4. So does this type of education for the trainers actually improve their outcomes as trainers? And there are very few courses which have got this level of information about the actual course that's delivered. And we found that actually when the trainers, the experts, did this type of methodology and went on the course, it decreased the learning curve for their residents. So it's really important in these pandemic times that every time we get a training opportunity, we maximize the training opportunity. And by using this methodology, a particular structure around training, we've shown very clearly, this is published in the Annals of Surgery, that we can actually decrease the learning curve.
Thank you very much.
Because I don't know if it's because of the COVID, but everybody is talking about training the trainer today. That's probably, as you say, that we have to really get the most of the time when we're training people. And this is a very interesting topic. And I think that's probably one lesson from also this very special period of time. I would like to go back to, again, to England and the Royal College. Do you have some slides to show about the changes of your program, both in your own work in St. Mary's, and I know that you're working with this company also. So what is today the method that you're using for education?
Yes, thank you. Can you see that?
Yeah.
Oh, hang on. No, hang on. It's just before I start, it's interesting you mentioned about training the trainer, and I often wonder, it's not just about making us into better trainers. I also think there's a certain quality assurance like industry with it, and that I think we all need and trainees deserve. I really enjoyed that last presentation. It's nice to see evidence coming out that by doing what we're doing, we can improve not only our trainees' experiences, but also ourselves as part of our professional development. It'd be interesting to see, is that kept up 6 months, 12 months, and 18 months later? One would assume it is, because trainees move on. But I'm going to talk just slightly different about what I see as an adjunct to our training and to trainees, and even for ourselves. We're all, certainly in the UK and Ireland and the United States, and I assume it's in other countries in Europe as well, that we have this continuous medical education that is mandatory for our continuous development, both professionally and also for registration. And I think the public demands it also. And I think we have to embrace the new technology that's out there. And again, this is very similar to the Kirkpatrick. It's just a slightly different way of looking at how we learn and the cone of learning. And I think just because COVID has been foisted upon us doesn't mean that we take a back seat and wait for it to pass, because we still have an ongoing commitment to our trainees and to ourselves to keep our skills up. I don't know if you look at the screen on the left, if you're familiar with the term Luddite, L-U-D-D-I-T-E. They were a group of workers in sort of the 18th century in England, who were very much against the change in technology, in particular the weaving mills and the cotton mills. And they felt that their jobs were under threat as a result of the Industrial Revolution, but also they didn't believe in this technology, and they went around smashing a lot of the modern technology. So nowadays, if you call somebody a Luddite, they are people who shun modern technology or certainly the changes in technology. And it doesn't matter whether it's forced upon us in the current pandemic environment or whether we do it by design. If the environment changes and we don't adapt to it, then I think we are all at risk of becoming Luddites ourselves. On the right-hand side, for those of you who are familiar with Star Wars, I think the traditional approach to surgical training of having mentor and mentee, I think that will continue, albeit in a slightly different way. And I always think, certainly as a trainer or a mentor, we have that sort of almost tangible responsibility to our trainees to pass on our knowledge.
Ouais, moi aussi, c'est pour ça que j'ai des questions qui vont.
Just very briefly, it's a busy looking slide, but if you look at to summarize, children learn differently to adults. You know, children like to be taught and told what to do, then they get a test, then they get a reward, and that keeps them happy. Adults, on the other hand, need feedback. And what we do know from all the educational experience, and I'm not an educationalist, what we do know is that adults respond better to their own self-assessment, their own self-reflection. And I think as long as we can continue that environment of learning and self-reflection amongst our trainees, I think we do okay. So to skip on and move on quickly, I want to talk about two areas that we have done before the pandemic. The course that I alluded to earlier on, the Definitive Surgical Trauma Skills course, which was cadaveric dissection. You can't replace that, but you can augment it with virtual reality. We had books that, we printed a book that went with the course that is available for trainees. And we had online Moodle platforms with videos, modules, and self-reflection exams. So over a period of about 5 years, we slowly adapted to the changing environment of our trainees. And similarly, e-learning for healthcare, which is a collaboration of NHS Health Education for England and the Royal College of Surgeons here, have also adapted the virtual learning environments. That's what we had before. Now I feel that the virtual learning environment, I think, has become even more important. And I have done a little bit of work with digital surgery and touch surgery and Medtronic before, developing virtual learning environments, but slightly different. It's not just a straightforward video with a narrator. And I'm going to show you just some examples where you try and engage the learner, be it a master surgeon or indeed a novice, but you try and engage them using smartphone or smart tablet technology. And these two operations, now it's open surgery. I appreciate we're talking about minimally invasive here mostly, but the take-home message is exactly the same. So on the right, you have on one smartphone, you can have, if it works. So you have a blend of open surgery and illustrations on the bottom, and they are essentially complementing each other, and slightly different views on the right-hand screen of the exact same operation, but you can move between different screens to see what the master surgeon is doing, i.e. the trainer, so the trainee can take away. And I do think you need a combination of both live video and illustrations on video to make it really tangible for the trainee. Here's another example of some nice video. You can use smart technology to show a very junior surgeon coming in, how you want to position the patient before surgery, how you want to prep them, and then you can take them through, before they even come to the operating room, exactly what to do. So I'll play the one on the right, and I'll speak through it. You know, we can finish at any time, so it might be a little bit long, but you can show a trainee can have this under a smart device, can look at positioning the patient, and it's also understanding. And every time you see a small green dot come up, it means that something's going to happen, or the trainee or the surgeon is going to do something. In this case, it's giving an understanding of, this is for thoracoscopic sympathectomy, for example. So it's minimally invasive, very difficult to teach someone this operation. It's not very common, but you can show the position of the patient that you want. It can show what the background anesthesia is. We can, as you flick between pages on the smart device, you can see the various anatomy that's necessary, the physiology, how to prepare themselves, what equipment is necessary, and it gives them a much deeper understanding, I feel, at almost a visceral level of exactly what is expected before they go in and hone the skills of the hand-eye coordination. And really, at the end of the day, nothing can replace hand-eye coordination better than hands-on surgery. And we know that, and that will continue forever. But why not have yourself so well prepared? It's a bit like the old adage, if you fail to prepare, you prepare to fail, essentially. And here's some live footage, again, which complements the digital surgery side of things, showing the anatomy, Some of you will be more familiar with this. It's inside the chest. And as you go along, we label the anatomy, things that a trainee will not appreciate. The vagus nerve, we've got the left phrenic nerve, you see the heart beating in the inside. And it takes a long time. Obviously, we can show exactly where the sympathetic chain is, and how the surgeon can carefully and slowly divide it. And as you go along, you augment it with your anatomy, with your nice illustrations, which you need. Now, we know medical illustrators are often optimists, and hence I like the blend of showing what it really looks like versus what they should know in the illustrated textbook idea. I guess one of the disadvantages of this type of technology is it takes a long time to gather this sort of information. Perhaps endovascular surgery and certain types of laparoscopic surgery, you may get it sooner for common operations like lap choles or Nissen's fundoplications, or in my specialty, doing an EVAR for an aneurysm. But with the more complex and esoteric type operations, perhaps some of the pelvic work that's done amongst colorectal surgeons, and indeed sympathetic or thoracoscopic sympathectomy, it can be more difficult to capture good quality video. But I think it's a case of adapting essentially to the environment. And as you see as we go along, I'm essentially taking out the sympathetic chain here and showing the anatomy far better than I ever saw it as a trainee. And I would hope that the blend of modern virtual reality technology with video enhanced and instructions on a smart device, which pretty much everybody has nowadays, should be a nice blend. In addition, I'll say smartphone technology, I think, is pretty much available all around the world. So it doesn't matter if I do this in London or Seattle, you know, or Mumbai or Melbourne, Australia, you can have the same virtual platform going out to everybody all around the world. And I think, if anything, it's making the global village of surgery a lot closer together.
Very, very, very interesting technology indeed. So Arnaud, do you like to show some slides on your new project, or would you like to comment on this technology? Do you have slides? On peut pas t'entendre.
I can try to share what here we have done, and you know that I don't know if you see. So the very small video is 2 minutes, and so I mean that what we have first, that we have this school is Miss Academy, and we have totally the website. We have to move it from a simple information website to an interactive website where people can get master classes, can get in contact. And the good thing of this is that we have been able to gather more than I don't know, actually we should be 300 experts in gynecology that not only are expert on the website but are active on the website. And so, you know, it gives the opportunity to everyone to get. The second thing we have shown, and this is the most interesting part, is we try to move the hands-on online. And it was a challenge, and you know, we have done this. I think suturing in laparoscopy is quite a complex task, and so we have launched this online suturing with the platform. So this is a real complex organization. So every participant has the same tools that they receive when they register to the course, and then they got a course. And the feedback of those courses is much better than the online courses that we are making. And another example, to be fast, you know, I am very involved in very young people education, what we call the winners in gynecology. And what we have made, we have organized an international competition online where people was gathering in their country, selecting the team in their country, and then after online, they were competing in different tasks. So I was making the clown as usual in different background, as you see, but it was amazing. You know, it's amazing how people got involved really. so I think that this is a bit the future. Future could be this kind of hybrid event where you have at the same time small gathering event in places, and then you have more online international gathering, or the opposite, by the way. We could do selection online in the country, and then we can eventually make the final competition, for example. What I want to show here is one, if you use the technology online, and for me, the virtual simulation is a part. You know, since always I told to all the companies that are in simulation, I say, you know, you have to be online. So for me, there is no market that we all buy these very difficult or expensive hardware. The hardware should be online, and people just play from their home on the platform, and this is the future. But I was telling that before the COVID. What I want to show by what I show you is one, the fact that we are online, so we just break the barrier of the distance. We just break the barrier of all the time consumed to travel, to stay, to go out of your job. And so mainly, if we are a little bit curious, if you have a little bit of imagination, if we have a little bit creative, I think we can really do things. And I wanted to show you that this is the first try we do on online, very simple tax suturing online courses, and with an excellent feedback, but I'm sure we can do more. And to show you how you can gather people online with the same atmosphere quasi that when you are on site together. And so this is with this hope that I work, and I quite hardly in that way, because, you know, I think that what we discuss is knowledge. Knowledge is very easy to deliver. Nowadays, ignorance is a choice. So knowledge is not an issue. More an issue is understanding. So how the people go from knowledge to understanding. And I know this is an old French debate or philosophical debate, but this is still, I think it's very accurate today. How we move from knowledge to understanding. And this is our problem with surgeons. Because you may be a very good guy to suture, and I understand that we should acquire those tasks before going in the OT. But, you know, making a nice knot on the wrong place is still a wrong suture. And so, and the last thing is how to move from this, we're discussing from this understanding to the next level, which is, in my opinion, the surgical intuition. And so this was the gap, you know, the missing link. And I really feel that nowadays, with gathering our experience on site, capacity online, we are going to fill the gap. And we have a lot of challenges because we don't talk about that. But I think my predecessor from England told that it's very time consuming to give even to the simulator the data he needs to make the simulation. It's very time consuming to animate a website. It's very time consuming to do everything. And beside, by the way, it costs a fortune. And so, I mean that, alors Bernard, you are in this beautiful environment of IRCAD, and I am there very often, and we are like spoiled boys, and we have all the tools. I'm sure you have around you at least 4 technicians. But I am alone in my office here, and I have to do the job. So, I mean that this aspect of time consuming and financial resources has to be addressed. And if we address those aspects, I am sure that we will be much better than before.
Thank you, Arnaud. It was very interesting, and listening to you, I was making a comparison. I'm a fan of racing cars, and you know that in the beginning of March, all the Formula One events were canceled because of COVID. And apparently there was a big development of e-games. And everybody is loving cars, thought, okay, no, I'm not seeing the car, not touching the car, it will never work. And this is today an event that is enormous all over the world, gathering, as Arno is saying, a lot of people playing, making competition, etc. So it became very popular. And initially, for an old guy like me, was no, will never work. So I think that the idea of Arno of changing the game, I think it's quite interesting as an attitude and an initiative. So I'm very impressed by your project, and I'm pretty sure that it's probably a good direction. So I would like to have the advice of Dr. I'm sorry, I missed my papers. Dr. Pikowski from Poland. What is you? I know that you said that you have to stop all your program because of the COVID, but I want also to look a little bit of what is your feeling and your prospect regarding these problems.
Okay. Can you see my slides?
Yes.
Okay. So first, I have to mention that my presentation won't be so spectacular like previous one. I mostly focus on this practical. Did we really change something in our clinical practice due to this pandemic? I'm not talking now about the future, what we want or what we think to develop, but it's really in our clinical practice or training change. So first of all, when we start at our center, 70% of major resection was performed by VATS, and it didn't change. It's the same before and now during the pandemic time. And as I mentioned before, the thoracic surgery training have three pathways. There's residents in thoracic surgery, other specialties, and this minimal invasive courses. And as you can see, and when we are talking about thoracic residents, so they have limited time of residency. So they should be trained during the 6 years of practice. They usually work at our department most of the time. So it's kind of staff, they're kind of staff member of our team. So in fact, in practice, nothing changed. And because of this pandemic time. That everyday work looks and training looks in the same way like before. When we are talking about the other group of residents present of at our department, what we change, of course, before coming to our center, we have epidemiological interviews, some testing. We limit the number, so it just one resident, not no more during the same time, just to limit the number of surgeons or residents on OR. All the theoretical part of training, we just moved for the e-learning, not lectures like before. We try to ask them to not work at the emergency room during our training. It's just the safety, and also to follow all the safety rules. But the main difference is, as I mentioned before, regarding these minimal invasive VATS courses, because they were stopped. And they were stopped, why? Mostly because of the organizers, like Medtronic, for example. They stopped organize this kind of courses. And it was for me quite clear on the beginning of the pandemic time. However, now in September, when I was asked for this to join this webinar, I asked myself why these courses are closed. Because in my opinion, there's no spectacular risk of contamination when the group of limited surgeons and scrub nurses join us for a few days. Of course, I leave the problem of transport, airplanes, and so on. However, I didn't say, in fact, I cannot see, if you can train our residents here, we can train also some visitors in the same way still. But it was in September, and this curve, as you can see, this is the rate of new cases of COVID cases in Poland nowadays. As what we observed during the last 2 weeks, this a significant increase of new cases. And now the question is it really true? And now my point of view differs a little bit. However, I'm really convinced that new technologies like virtual programs will develop rapidly nowadays. However, still will be the need of typical hands-on surgery, because it's not only surgical skills, what I think, but also this perioperative care of the patient. And when this ERAS program, for example, for surgery, which is quite close related with the with minimal invasive surgical techniques. So I think that this will fluctuate and change depending what is the state of pandemic all over the world in every country. However, I think I'm convinced that still will be in the future place for this kind of hands-on surgical courses, probably not so often like before, probably combined with other options. However, it's still, I think, good and effective method of training. Thank you.
After discussion with Olivier, the issue of what we can show, what we can do, what we can propose as a content in the webinar or masterclass or whatever, or you call it, I will just show you a 3 minutes sequence of the program of IRCAD. Of course, it's I would say theoretical education. We're not addressing the hands-on, and just I let this video run. So this is the old time. People were used to come to IRCAD, and today we have changed a little bit, and I will show you if the technicians are ready. The small video just showing what we've done today. So it's different, and what we're using to try to continue this web education. I don't know if it's coming. Okay. Because this is the old educational programs. So I want to show the new one. They don't have it. I ask it, but okay, prepare it for afterwards. So the idea was just to show you a little bit what was not done in the past, but done today. But it's not a problem. We already respond to some of the further question, because as we've heard from different people, we all agree that on the education, I would say we are good in web education. We can promote a lot of ideas, a lot of programs through this web-based. But the question of hands-on has been addressed a little bit by Arnaud, who developed this very interesting platform where people can practice for basic suturing. But I would like to ask again the question, besides Arnaud, how you can see the problem of hands-on. Do we have to change something? Do we have to adapt to other methods? What can be this sort of methods? So there is a big question. And also the question is, when we will try to control this pandemic, what will be the attitude of people? Would they love to come back to on-site course, to see people, to forget social distanciation? So will it be a big increase of the demand on this on-site training? So I would like to have a little bit your feelings about this problem of hands-on. So I will start again with Dr. Gupta. So how are you seeing this future, quite near future, regarding hands-on, not only for residents, because we know that it's quite easy, I would say, in the institution, but for postgraduate training, for example? How do you foresee this problem?
So I think that the pandemic has given us some really fantastic opportunities, because I think, as one of the speakers said before, we never used Zoom before the pandemic, and we have all these new opportunities. And I think it's going to make training more democratic, because in the past, I think, as Morgan said, it's quite difficult for people to get time to go to courses. It can be very expensive. With Medtronic, we've been doing these LAPCO Train the Trainer courses throughout the CIMA region, and we were running them in Istanbul with surgeons coming from the CIMA region to Istanbul for face-to-face, a 2-day course. Now, there are people around the world who aren't able to travel that far. Maybe they don't have the financial resources to do that. And what we've done, we've run 3 of these courses now online. And initially, I have to say, I was a bit skeptical about running this Train the Trainer course online, because it really revolves about group discussion, peer-to-peer discussion and training, and I didn't see how it would work. But we've run 3 courses really successfully with people from all different parts of the globe. And I think it's going to be a fantastic opportunity for people who wouldn't ordinarily be able to access these sorts of educational resources to access them. I think it's nice to have the face-to-face, of course it is, but I think it's going to be a mixture between the two in the future. And I think that's a really positive change that the pandemic has brought for us.
So I really know with what I wanted to show, just to give you some ideas about the potential for the thing that we can transmit to the web. So, for example, here we have some sort of class inside of the operating theater. So we are showing live surgery. So all the participants are in a direct connection with the operator inside of the room. So the operator can show the clinical case, discuss the clinical case, the indication for surgery, and then we can show the different phase of the live surgery. Then we are mixing different education program. So of course, lectures are the base of education, as Arno was saying, but it's not enough. So we have also tested other solutions like the anatomical dissection, lessons of anatomical dissections. For example, we did that in neurosurgery, and you see that we are connected to the lab and we can show anatomical dissection. So it's also something that is important. I believe that anatomy can be taught through the web. We don't need automatically to touch things to understand the anatomy, and Arno maybe can comment on that. So you see there are a lot of different options that we can propose to the participants. So Olivier, I'm pretty sure that you have a question from the audience or remarks from the audience or personal remarks.
No, I would say yes, many questions have been addressed. I would say I had many comments concerning the time consuming. So Professor Vattiez mentioned that concerning, yes, the time
and finance.
And finance as well. And also because of the COVID-19, so, you know, you start your procedure very late, finish early, you have some breaks, and you have less and less time to do your work and your training. So it was a comment that has been that has been largely shared online.
Okay, so from the participants, no special question?
I mean, many questions has been addressed during our discussion. So
okay, so we'll move on the program, and I invite the faculty, if any of you wants to address some of the concepts that were presented by our partners. Feel free, you just push on your button and you ask your question. So some comments or suggestions or evaluation of the initiative of your pairs, feel free to comment for the audience. Arno?
Well, I have a question, and I want to bounce on what Dr. Piskowski message, subliminal message was passing. And as I told, you know, it's time consuming, needs a lot of resources. You have to get all what we have before. You have to be courageous, creative, imaginative, whatever. You have to work hard. But then now we have to organize. You know, I mean, when I talk here, my brain is organized. I talk to you like this. I do not prepare. It's fine. When you do something online, it has to be prepared very nicely, and you have to. We almost speak about algorithms to anticipate the question, online question that you cannot feel because you are not your public in front of you. And so this is time consuming, and this is also financially expensive. And so the question to mimic, and I observe also like Dr. Pivkovsky, the kind of evaporation of our sponsors. And I am a bit surprised that my feeling is we do better. My feeling is we do better. And so I do not understand this evaporation, because this is now that we need the help of the sponsor. And I think that the Medtronic step tonight is probably a good sign. But like Dr. Pivkovsky, you know, to cancel purely and simply event is not the answer. You know, you have to replace that by something, and this something has a cost, has a human cost, has a financial cost, and so we should have an answer to that. And so my question is, I don't know to whom to get the question, where are our partners?
I have a partner just next to me. He's the victim. I think, Arnaud, is a very nice question, because I think that if this company is organizing this sort of discussion, is because they want to know a little bit how they can support the different programs, and probably choose the programs that correspond the most to the philosophy of the company. Am I right?
Absolutely.
Olivier?
I would say, yeah, during this period of time, so it's of course we adapted to the situation as the surgeon cannot travel anymore, and a huge number of webinars has been organized across the different specialties, the different programs. So I believe I cannot reply for all the industry, but I believe yeah, many events has been set up. So yes, and reaching 1,000 and thousands of surgeons during this period.
But as a company with the needs, do you find in these different proposals from our participants, do you see some potentialities, some interesting points, or some interesting ideas that a company, large company like Medtronic, we know theaters, that's for sure. But are there other projects that your company would be interested in that?
Absolutely, yes. Of course, we try to explore all the different solutions. So, and especially to keep all this webinar more and more interactive with, as you described, with live surgery, with roundtable between experts to share knowledge, as well the simulation. So it was presented with touch surgery. So yes, I believe we try to explore all the different possibilities to have an alternative to the hands-on, and to make sure that we can continue to support the training and the educations.
Yeah, but I know that you are providing medical devices. And medical device is something that we should train to, because using that in the patient. Do you think that for a company like Medtronic, that would be interesting to do some webinars showing the different instruments or the new technologies, and developing some program to ease the understanding of the users on the other side? Does it make sense, or have your company think about that, or what's your opinion on that?
No, it's a good comment, a good question, because yes, we had already few projects like that. As you know, everybody learned during this period of time, so on all these tools, and yes, especially this kind of events, focusing on how to use the products, but as well all the recommendation of use, yes, are going more and more. And so I've already 2 or 3 on schedule.
Okay, that's good for all the people around the table, because we have the programs, the scientific program or the scientific background. You have a company, and we maybe could cope a little bit to support this sort of programs, maybe by also showing you technology. So that's maybe an interesting mix that we could develop to promote this sort of support for people who need some support, as Arno was saying. That I'm very pleased to be in a big institution, but I know that people do need support to develop and to organize this sort of program. It takes a lot of time. So Arno, vas-y.
Yeah, no, I like what you said, but I mean the situation is not to redo tutorial that you can get on YouTube. I mean, you know, when I have a problem in my house to repair something, I go to YouTube and say how to repair that, and I got my tutorial, so it's fine. This already exists. Huh? It's nothing. No need to reinvent the wheel. What I want to say, I would like, and this is a question that I want to ask, and this is after the comment of Dr. Gupta, and when she speak about the democratization of the learning, and I think this is totally correct. So I think probably people in remote countries that cannot afford to travel may have access to teaching, and this is fun. I would like to raise a question about the democratization of training, and because it goes with, and now, as you say, we see 1,000 of webinars, you know, and my question is, and this is also for Dr. Pivkovsky, that because we are in main centers with experience, background, experience in teaching, experience in surgery, I think you cannot improvise yourself teacher the next day, but today we can. So today, with the help of whoever, you can do a webinar on whatever, and we come to the pure criticism of internet education about the value, the pertinence of the information you receive. How are we going to address this problem, in your opinion, or all the opinion of the faculty?
I think that probably on our side, one solution is, of course, to go through the process of getting credits, official credits, because you know, as I do, that when you want to have credits, you have to go with a formal program, as you say, very well organized program, very well webinars, and you have to submit that to the national or international authorities who agree on your program and give you credits. So this is probably, to my sense, the best option to get the validation of the scientific community. But that's only my opinion. Probably I will ask the same question to the other speakers. Arno, I agree totally with you that you can get a lot of things on YouTube, but you have to have a validated educational program, and that's a big question. So I will start with Dr. Gupta. How do you think that we can validate the programs that are proposed?
So I think Arno's question was absolutely right, because there is so much information out there that if you are a resident and you go online, you know, and you follow a training program, how do you know that that training program is going to be effective? So I think what you said is right, that in our own countries, we can apply for the credits, and then we know we have to go through a process to do that. We wrote and published a paper called Lap Vegas Guidelines, which was looking at the videos that you put online and doing that in a really structured way to make sure that it met the training needs of the person watching it. So I think that's also worth looking at. And within a training program to see, have you got accreditation? Have you got data? And can you show that it's going to make a difference to the output after the person has gone through that? But I think it is, as we're getting into more and more of this web-based training, I think we do need to come up with some kind of international way of accrediting these training programs so that people know what they're getting.
Okay, thank you. It's very clear. So, Dr. Pawłowski, how do you see this validation of the online programs?
Well, I completely agree that it's a very important issue, because nowadays you can reach on the MedTube or YouTube very spectacular surgery, which is just prepared, because all we like to show how difficult surgery we can do. And I think, that sometimes it can be even dangerous, because when you look as an ambitious resident, what you can do by VATS, or how complicated cases you can do, and then you want to follow as soon as possible, it can be dangerous for your really practice. However, so it's an issue. So that's what we started to do before pandemic, and nowadays I think it's also, when we are talking about this online education, that it's very important. Just don't only cooperate with let's say commercial companies, but also have some affiliation to international scientific organization or medical, like for thoracic surgeon, like ESTS, European Society of Thoracic Surgeons. If we are prepare something on the international level, when we are prepare something on the national level, I think it's good to have an affiliation with national institution official, which in some way make these presentations or discussion maybe a little bit more valid or objective, not so not controlled, let's say.
Dr. Moneigel, what do you think about that? What is your opinion? I think that
I agree exactly the same. I think that you need some sort of academic respected body to at least be in sync with the course. I also think that trainees are far more likely to spend their time and potentially money and effort partaking in a course that is recognized either by a national body, such as one of the British programs like ASGBI or even a GMC, or indeed something that's more pan-European or indeed international, as long as it's authentic and recognized, that it's a form of quality assurance, and I think you'll attract more participants that way too.
Okay, excellent. I think it's an excellent conclusion for this this discussion. I think indeed we have to validate what's proposed to the students or the different attendees. That's probably something that we should work on, and maybe with the support of the company who's allowing, because we know the work of Dr. Gupta on the videos, and this is a very interesting program that we apply in our institution, but it was a very good initiative, just helping people to understand what they're seeing. This is very important. And today we are in the same situation as the problem of the video. We propose videos, we propose something like a video. So we have also to develop this guidelines, and probably we can look at the way of Dr. Gupta and her team has developed this Lab Vegas guideline for videos. That may be some inspiration. So this is very important. It's a very nice conclusion for this discussion. I would like, in the name of Medtronic, thank you all. It was a difficult subject initially, and finally you did it very well, because we got a lot of very interesting information, and I'm pretty sure that Olivier and Medtronic will organize another one where we'll come with a concrete proposal on the methods to, I would say, support and validate some of the method that people are proposing. So thank you very much, and take care, of course, today. Thank you. Bye-bye.
Goodbye.
Thank you. Goodbye.
Thank you.
Thank you.